Hello, my name is Mark Simmons. I'm a consultant in acute and critical care medicine here at NUH, and I'm here to talk to you about severe sepsis, which is a problem across the trust, but is particularly important that you in the surgical specialities are picking up these patients early and giving them the treatment that they need. Now, you may have heard historically about the Surviving Sepsis campaign, which has been a global challenge to try and improve sepsis care. But at Nottingham, we've tried to simplify this as much as possible into 3 simple steps. Firstly, in order to treat the severely septic patient effectively, you have to recognise them, and we have a number of methods and number of ways of helping you with that. We have our EWS charts and a screening tool on those charts, and we expect you to take blood cultures from every single patient that you think has severe sepsis, and also a lactate level. Now, lactate, as you all know, is a marker of anaerobic respiration, but can really pick up the patients who look physiologically fairly normal, maybe with just a bit of tachycardia, but can really show the patients who are even sicker than they look from the end of the bed. Once you've recognised the patient, you have to respond, and respond quickly. And the key to this for the severely septic patient is getting antibiotics in less than 1 hour. This is a target that we've been trying to hit here at Nottingham for the last few years, and our current compliance rate is somewhere near 75%, which is a huge improvement over the last few years. We're trying to maintain that and improve further, so please play your part in that and make sure that you're writing up antibiotics on the front of every drug chart as a once-only medication for the first dose, and then writing on the inside of the drug chart the ongoing antibiotic course with a stop date or review date and an indication on the antibiotic prescription chart. Also, for those patients that require fluid resuscitation, i.e. those with a high lactate or low blood pressure, we expect you to again get that in as soon as possible, and we would recommend a litre of Hartmann's or an equivalent crystalloid solution over 30 minutes in the first instance. Now, if antibiotics and fluids have not made a big difference and the patient still remains physiologically unwell, then that patient needs to be somewhere else, and they need to be off the surgical ward and in a critical care area. We expect you to have made that referral within 6 hours of their deterioration, so the clock really is ticking. Once the patient is in critical care, they can then receive a central line and inotropic support in order to maintain blood pressure and organ perfusion. So time really is of the essence. Now, at Nottingham University Hospitals, we've done a number of things to help you and to remember what to do with a severely septic patient. The first thing is the severe sepsis checklist or sepsis sticker, which is available on all of the acute ward areas, and is basically a sticker to put in notes and remind you of what needs to be done. We've also got severe sepsis toolboxes in all of the acute wards, and a severe sepsis website which will give you all of the background and all of the detail that you need for the day-to-day work on patients, but also can be helpful for exams, etc. On the back, as I've said previously, on the back of the observation chart, which is at the end of every single patient's bed, is a severe sepsis screening tool. This is mainly for nurses to use, but there's no reason why doctors shouldn't be referring to this. It really takes you through a very simple protocol as to what constitutes severe sepsis and what you need to do about it. And finally, you will see a number of posters and leaflets around the hospital reminding you, nursing staff, and all people involved in the severely septic patient that we need to get on with identifying and rescuing these patients as soon as possible. Finally, and in conclusion, I think the real key is that people treat severe sepsis as a medical emergency, as you would do an MI or a stroke, and it needs to be done soon. There is something we can do, and there are evidence-based interventions that make a difference, but time is of the essence. Thanks for listening.